Welcome to Commentaries in Hair Loss. I'm Dr. Jeff Donovan. I hope you'll join me as we explore some important questions from the field of hair loss. Our commentary today will look at the important question, how is hair loss diagnosed? And we'll use an algorithm to better understand a step-by-step approach to dealing with patient concerns about hair loss. This is an algorithm that I use in dealing with patients who present to clinic with concerns about their hair. The main point of this algorithm is that the evaluation of hair loss starts with the patient history, followed by the physical examination. We start thinking about potential causes of hair loss by understanding more about the patient's story and what their scalp looks like. We never begin diagnosing hair loss by looking at the blood test results, looking at biopsy results, or looking at any other test results. And that's really the key point of today's commentary, stressing the importance of the clinical examination and the patient's history. The reason this commentary is so important is we receive many emails and phone calls daily by patients who will tell us that they've received a certain blood test result and they want to know what it means. My ferritin is 12. Do you think this is impacting my hair loss? My zinc is low. My zinc is high. My testosterone is low. My testosterone is high. My thyroid is this, my thyroid is that. All of these test results may have relevance in the patient's hair loss, but they may not. And the only way one can determine if any particular test is relevant is by understanding the patient's story and knowing what's happening on the scalp. In other words, by following this algorithm. Similarly, we receive many patients' questions to the office about a biopsy result. My biopsy shows I have miniaturization. My biopsy shows I have scarring. My biopsy shows I have 17% of the hairs in telogen phase. What do you think about this? Is the question from the patient. And in situations like this, the only way that one can come to understand what's happening, and the only way one can ultimately be able to advise a patient, is by understanding the patient's story and what's happening on the scalp. These steps can never be bypassed. So let's take a look at this algorithm in more detail. The first step in evaluating hair loss comes from better understanding the patient's story. We want to know when the hair loss first occurred. How fast is it progressing? Does the patient look different than 2 weeks ago or 2 months ago? Or only different than 2 years ago? Is there itching in the scalp? Is there burning? Is there pain? Is there shedding? How much shedding does the patient have? Can they express it in their own words? Or if they need our help, do they see hair on the pillow? Are the drains clogged? Is there hair in their food? Is there hair in the refrigerator? Is there hair on food that's prepared at the dinner table? Are eyebrows affected? Eyelashes affected? Body hair affected? What's the patient's general health? What's the family history of hair loss? Has the patient been on any new medications? Have they started any new medications? Have they stopped any new medications? So all these factors are very relevant, and potentially there are dozens upon dozens upon dozens of different questions that may be relevant. Now, when one evaluates the history of a patient's hair loss, most of the time, the questions that we ask are negative, meaning the patient says, no, I don't have this or I don't have that. And so we have to be patient when we evaluate hair loss. Many of the responses that the patients will give us are in the negative, but we have to keep an open mind in terms of the variety of questions that we can ask. And once we feel that we have a good understanding of the patient's hair loss, then we go on to examine their scalp, Part B. The examination of the scalp really comes down to understanding where the hair loss is occurring. Is it occurring in the front, in the back, in the sides? Or is it occurring equally everywhere? What does the scalp look like? Is the scalp scarred? Are the pores open and visible? What's happening to the hairs? Is there just less hairs, but it otherwise looks quite normal? Or are the hairs becoming thinner or miniaturized? Are the hairs broken? And so the examination of the scalp really comes down to understanding what's happening on the scalp. The use of a handheld dermatoscope, or trichoscopy as it's called, is very helpful in evaluating hair loss and really is a key part of this Part B step. For many patients, it can be very difficult to be very confident in the diagnosis without the use of trichoscopy. Of course, for many patients, we can be fairly confident of the diagnosis without trichoscopy, but I think trichoscopy, or the use of these handheld dermatoscopes, takes us from being pretty sure of what's going on to being even more sure of what's going on. The examination also involves an examination of the eyebrows and the eyelashes, body hair, nails. And sometimes this involves just asking the patient during the history if they think there's any changes in the eyebrows or the eyelashes, but sometimes it involves looking if we're suspecting certain types of diagnoses. And these particular diagnoses often go along with body hair loss or eyebrow loss, and the patient says there's been no changes, then we sometimes want to examine these areas with the patient's permission and have them draw attention to it, because some patients may say, come to think of it, I used to have way more hair on my arms than I do right now. And so there are situations where we rely on the patient to let us know if there's been changes in eyebrows, eyelashes, and body hair, but sometimes we ask to examine these areas so we can have the patient give us a better assessment. And so once we understand the patient's story and we've examined hair-bearing areas, then we ask ourselves, do we need any tests? And there are many tests that can potentially be ordered. These include blood tests, biopsies, and there's many other tests that are possible as well, ranging from sophisticated blood tests to electron microscopy to swabs of pustules to scrapings for fungi. And so there's a whole host of tests that can be ordered, but that doesn't mean we need to order them in all situations. In general, a patient with hair loss benefits from an evaluation of a complete blood count or CBC, a thyroid study panel, an iron storage level, or what we call ferritin, and a vitamin D. So these 4 tests are extremely helpful in most patients. But whether other tests need to be ordered really comes down to understanding the history, part A, and understanding the findings that were discovered on the examination, part B. And so there are 40, 50, 60 tests that are available, but generally speaking, we don't order all of those tests. We only order a very small proportion of tests. But if the history shows that one of these tests could be relevant, then we order it. A patient who says that she's fatigued, she has joint pain, she's much more sensitive to the sun than she used to be. Her hair is falling out, it's thinning, she doesn't feel well, her blood pressure's been off. We might order an autoimmune panel in this patient, including an ANA. A patient who has a chronic history of bowel issues, frequent diarrhea, family history of bowel issues, we might consider ordering a zinc level, whereas in other patients, this test probably wouldn't be of much use. And so the blood test that we order really comes down to the information that we obtain in Part A and Part B. This is really important because many patients will ask us, I'm coming for my appointment in a couple of weeks, and I'd like to know all the blood tests that you might need so I can get them done now. Well, there certainly are a number of tests that are very, very useful to have, and those include the complete blood count, a thyroid study in iron, and a vitamin D level. There's no doubt about it. But there may be dozens of other tests that can be considered depending on the patient's story. And the only way you can ascertain the whole story is by having the whole story. And so unless you know everything about the patient, you really can't say what blood tests need to be ordered. Although a basic panel can be ordered and will be very helpful during the consultation. The other test that's commonly ordered in this Part C is a biopsy. Now, I would say for 95% of patients that we see, a biopsy is not necessary. But there are some patients that a biopsy is extremely helpful. After you listen to the history and perform an examination, the only way that you feel that you can be confident in the diagnosis is by ordering a biopsy. If one feels that after examining the scalp and after listening to the patient's story and reviewing their blood tests, that you're pretty confident with what's going on, you know the diagnosis, then a biopsy is not helpful. Some patients will say to me, can you do a biopsy instead? I know you don't want one, but can you do one? And I'll often say to the patient, I certainly can. But the real question is if the biopsy comes back showing what we thought the diagnosis was, then we're no better off and we're no further ahead. We thought that was what the diagnosis was, and there may be a small scar in the scalp now. But if the biopsy comes back showing something different, and I truly feel that I won't believe that diagnosis, then the question is, why did you perform the biopsy in the first place? So biopsies are extremely helpful in the right clinical context, but they're not necessary in all patients. And biopsies are not 100%. They can be extremely valuable, but they need to be taken into context with the patient's history and their clinical exam findings. Sometimes I see a patient whose biopsy result is that they have a scarring alopecia. Now, when you look at certain features of the biopsy, you realize that it is true there are features in the biopsy that are suggestive of a scarring alopecia. But when you examine their scalp, when you listen to their story, you feel that this isn't a scarring alopecia. this sample that was taken from the scalp was taken in an area that had a scar. But it wasn't a true scarring alopecia. This is a scar that happened from an injury when the patient was very small, perhaps in childhood, or they had an infection that resolved many years ago. And so we have to always remember the patient's history and exam findings when interpreting a biopsy. We have to remember the patient's clinical history and exam findings when evaluating blood test results. And so we take the history, we examine the scalp, we order blood tests, and then we put all this together and we make a diagnosis. Sometimes there's 2 diagnoses, or 3 diagnoses. And once we make the diagnosis, we need to ask ourselves, does this make sense? Does the diagnosis of alopecia areata make sense in this patient? Does the diagnosis of scarring alopecia make sense? A hair shedding disorder, telogen effluvium, trichotillomania. Does what I'm about to say to the patient make sense? And if it doesn't, then we don't go back to the blood test requisition form and think about what other tests we need to order. We don't tell our assistants to prepare the biopsy tray so that we can do another biopsy. If it doesn't make sense, we go back to part A and we ask ourselves if we've obtained all of the appropriate clinical information. Do I really know everything about this patient? Do I understand their background? Do I understand their social stresses? Do I understand their social history? Do I understand their eating habits? Do I know where they were born? Do I know their family history? Do I know what their dad looks like? Do I know what their mom looks like? How many family members have had a hair transplant? Now, sometimes this information is not relevant, but in tough diagnoses, one needs to ask themselves, do I really understand everything about this patient? What does the patient do for hobbies? How many times a day does the patient wash his or her hair? Is the patient on any other medications that I haven't asked about or the patient hasn't told me about? Does the patient have regular or irregular periods in the case of a female patient? Do they have children? Did they experience hair shedding after the birth of their baby? And so when diagnoses are challenging, we go back and we ask ourselves if we understand everything about the patient. That's where we go back to. We don't go back to simply performing more biopsies or more tests. Now, we may need more biopsies and more tests, but that's not where we go back to. And then we examine the scalp again. Did we really have a good look at the scalp? Do we really understand what's happening in the front, in the middle, in the back, in the sides? There's about 100,000 hairs on the human scalp, but it doesn't take very long to quickly go through the scalp and sort of ascertain if something doesn't appear quite right. Have we carefully studied the frontal hairline? Have we carefully studied the crown? Do I really know if the patient's eyebrows are the same or not? Have I examined the nails? Did I use trichoscopy? Did I use my handheld dermatoscope? Maybe initially I didn't think it was necessary, but did I have a really careful look at the scalp? Do I understand the degree of miniaturization? Do I understand if there's redness and scale in the scalp? Have I performed a careful examination? And then once I've reviewed that yet again, then I ask myself, with this new information, if there is any, do I need any more blood tests? Perhaps I didn't realize in the initial patient encounter that the patient has irregular periods. The patient has experienced considerable weight gain. And the patient's 34 years old, and I hadn't considered it before, but I'm wondering about an abnormal hormone profile, perhaps polycystic ovarian syndrome, that hadn't been discussed before. So I'm going to change the blood test that I now order. Instead of just a CBC, TSH, ferritin, vitamin D, those key four, I'm now going to order a more detailed hormone profile. So with more information, I'm going to extend the blood work panel that I'm going to order for the patient. Then I asked myself, do I need any other tests? I did a biopsy before, perhaps. I don't think this is the diagnosis. It just doesn't make sense based on what the patient is saying. Do I need another biopsy? Have I biopsied from the right place? I'm sure this patient has a scarring alopecia, but the biopsy didn't show they have a scarring alopecia. I want to biopsy again, but where should I biopsy from? Well, perhaps I'm now going to biopsy from an area where I have come to understand the patient is very itchy in that area or has a lot of burning in that area. Or perhaps when I examined with the dermatoscope the second time, I realized that there's an area that's very red, very scaly. There's pustules there. Perhaps that's the area where I'm going to take a biopsy from. And then we put it together again and we ask ourselves a second time, with all this new information, the new biopsy results when they return, the new blood work results when they return, does this make sense? And if it makes sense, then I offer this as a final diagnosis and I move forward with treatment. And of course, sometimes we start treatment and things aren't going according to plan. You thought the patient was going to do a lot better than they are. When we revisit the diagnosis in situations like this, we start again with the patient history. I was certain this patient had a telogen effluvium. They lost 35 pounds in a month, and I told them that their hair loss is from their rapid weight loss. But it's been 9 months now, and they're not getting better. Do I first go to the blood requisition form that I have on my table and think of other tests that I need to order? Do I think, well, perhaps I should order a biopsy now? No. We go back to part A and we ask, do I understand everything about this patient's history? The patient lost 35 pounds over a very short period. But what I didn't really appreciate when I was first interviewing this patient is that their hair loss or their hair density was different 5 years ago compared to 3 years ago. And it was different 3 years ago compared to 1 year ago. So I didn't quite appreciate that this patient had been losing hair slowly. I didn't appreciate that there was a strong family history of hair loss. I didn't appreciate that the patient really was aware that their scalp was much more see-through 3, 4, 5, 6 years ago, and that things didn't feel quite the same. This patient may have genetic hair loss, as well as a telogen effluvium or hair shedding from their weight loss. And so whenever a response to treatment doesn't go according to the way we thought it was, or whenever a diagnosis just doesn't seem to fit, we return back to better evaluating the patient's history and their examination findings well ahead of any need to order more blood tests or perform more biopsies. I hope this has been helpful for you. I really do feel very strongly that this algorithm can guide the diagnosis of hair loss. There are occasionally patients that will report that they've had 2, 3, 4, 5 biopsies of the scalp. Patients that have had blood tests for various things they've had other tests as well, and they're not clear what those test results were done for and what's the significance of the results. We should never be ordering tests unless we have a really good understanding of what the reason these tests are going to be ordered. And in situations where the diagnosis is not clear, or situations where the patient's not responding well to the treatment, we need to go back to Part A and ask more about the history, and then Part B, examine the scalp carefully. There are patients that have their thyroid tested every 2 months because they're certain this is a thyroid problem. There are patients that have their testosterone measured every couple of months, or some other hormones measured because they think this is a hormonal issue. There's no doubt about it that thyroid problems and hormone issues do cause hair loss, but when we listen to a patient's story and we examine their scalp, we can quickly determine whether a thyroid study is appropriate, whether hormone studies are appropriate, and whether we need to order any more of these kind of studies. And with that, I will conclude this particular commentary. I again hope it's helpful for you, and I look forward to speaking to you again.